Welcome to the Reinventing the White Coat podcast, where we delve into conversations aimed at helping you foster a healthy relationship with your career and yourself. If you're a physician feeling unfulfilled or burned out or want to prevent yourself from going down that path, then this podcast is for you. I'm your host, Jennifer Scher, pediatrician, chief wellness officer, and executive and life coach. Sit back and relax as we explore ways to live your best life and have a career in medicine. Today I welcome Dr. Sabrina Braham. Sabrina is a community pediatrician who, in addition to teaching, is using her expertise as an advisor and innovator focused on leveraging technology to improve child and family health. Sabrina, welcome today.
Thank you so much. It's such an honor to be here. Thanks.
I always love talking to people related to kids, as everybody knows. And Sabrina, we met, it was at the AAP in 2023. I missed it this year, but last year's AAP, we shared breakfast and you shared a bit of what you're doing today, which is amazing, and I can't wait to hear about it. But you also shared a bit about your journey that led you to what you're doing today. So I really, you struck a chord with me, and I wanted to have you on today to share about your journey and also where you landed. So I am going to toss it to you and ask you, where do you want to start?
Sure. Well, I can sort of give you the high level story that is sort of the easiest way to explain how I ended up doing what I'm doing now, starting out as a general pediatrician. So maybe I'll start there and then I can dig into the details of how that transition occurred.
Terrific.
So I'm a community pediatrician. I trained at Stanford and then I joined a community practice, one of the larger community practices in our area. And I was in practice for, well, now it's been 15 years, but I guess at the time it was 11 years. And I think before COVID, I would have said I'd be doing it forever. I absolutely loved it. I had an incredible work-life balance. I'm obsessed with kids. I'm obsessed with families. And so being able to partner with them every day and then partner with my partners who I learned so much from as my career trajectory sort of took its journey out of residency was really all I could ask for. I think one of the things I look back on is that when you have, I think like many women who are working physicians, when you have achieved work-life balance, a lot of the struggles that are facing doctors maybe are less poignant because we've sort of managed to either avoid them, or in my case, I kind of actively avoided them, really sort of thought, well, administration is really not my bag. I want to focus on families. And so I didn't let myself, I think, get too focused on all of the struggles that get in the way of us being able to provide optimal care. And because of that, the stories that I could tell about my experience during my practice are really about how I would be on the phone with a family as I was driving home from a full day in clinic and realize that the only thing keeping this family out of the ER was a visit with me. And so I would drive back to the parking lot and examine that kid in the parking lot. And so those are the kinds of things where I felt I could give of myself that way because I had work-life balance. Obviously, if I were working, 5 days a week, seeing 25, 30 patients a day, I don't know that I would have had that sort of ability to give of myself that way. And
Now,
I
was
think
that specific to COVID, do you mean? Going back to the parking lot, or was that?
no, that was
No.
before. That was before, and I think my partners and I, that was sort of a normal thing. I think we prided ourselves on giving the highest level care that we could, and it certainly wasn't an expectation, but that's the level of commitment that I've seen around me from pediatricians to families, and why I have such deep love for pediatricians is that
Yeah.
we care so much about our families, and the idea that a child that doesn't need to be in the ER would end up there because of something relatively simple that you could do. I'm not saying that we should be doing this. I think that was probably outside the normal, but that was sort of an example of how I felt I was able to mitigate that. The pressure to feel like my efforts to help families were overwhelmed by the administrative challenges. Because the case of that particular child was that the staff were so busy that that mom had called at 7:30 in the morning and no one had gotten back to them, right? And so no, it's no one's fault. It's that the system, for instance, wasn't adequately set up to meet the needs of that family. But if I could do something about it, I was going to try and do something about it. So, so I think, so that's the scenario pre-COVID. And then what happened in COVID, in my experience, is two things. I think my experience of the rollout of mitigation efforts. So initially it was testing, right? Who has testing? Where's the testing? And uniformly, there was no testing or consideration even given for testing of children. And, you know, and in the early days, it's funny to look back now because all of the sort of visceral feelings we had are so distant. But
I remember those feelings vividly.
Yeah. And so what happened in our practice is that I was part of a large multi-specialty practice, majority adult patients. And we were, you know, with 14 doctors, I think, 14 pediatricians within the setting of this large 60 doctor practice. And so the decision was made, like most places, we're going to close to clinical care. The issue is that most of my patients, the families were employees at Stanford Hospital. So everything from custodial staff to ICU nurses and attending. So these were first line healthcare workers. And so we closed our doors and I was getting calls from them. My child has a fever. I have a fever. I was exposed. You know, all of these sorts of questions that came up. And the answer we were supposed to give was go to the emergency room. And first of all, it's not appropriate when, you know, when we could have easily taken a look, checked the ear, all these kinds of things. But also I called the head of the emergency department and I said, do you want us to be shunting all of our patients to you? And he said, we do not have capacity. Please don't do that. We will send you PPE. And so the conclusion I came to very early was that we can handle this. We had one exam room that had an exterior door. And I thought, okay, well, let's understand the information that we have available about COVID as well as we can, create protocols. And I actually used prior publications from prior pandemic epidemics, that sort of thing, to design protocols. And we said, okay, we're gonna stay open in that one room. We'll see kids, we'll triage them and see the kids that absolutely need to be seen. So these families can decide, can I go to work? Can the kid go to school? At that point, the schools hadn't been closed yet. And you know, I'll just give you an example with the PPE. So when the emergency department head said, we would be happy to send you PPE, and you remember how limited the supplies of that were, we were reusing masks for weeks.
So I remember
you know,
we had them in these little brown paper lunch bags, right?
Yes,
to keep
right.
them.
I mean, I actually remember we counted all of the supply that we had and we locked them up because we were taking them home. And we wanted to make sure we could take care of patients. And so, you know, with the instance with the PPE, we reached out to our administration and said, look, the emergency department doesn't want us to shunt these patients. We are happy to see them. We need your help coordinating the supply chain of getting the PPE so we can do this properly. I mean, I suppose I could have driven to the ER, but for whatever reason at the time, that wasn't how they wanted to do things. So, what ended up happening is that, and this is big picture, I think that there was a big shift from administrators telling us how to run our practice to us telling them how to run our practice. And that was probably I think that was probably the linchpin in the series of events that happened afterwards. But I think in retrospect, that was coupled with fear. I remember, you know, my colleagues, there were some who were in tears every day because we were all still going home to our children, right? You know, there was one who went on medical leave immediately. So my experience of the pandemic, especially in the early days, is that every one of us faced it in a different way. And I have zero judgment about that because we all have different challenges that we're dealing with in life. And so my interpretation of that was, let me focus on the patients. And actually what we did with the clinical space that we were going to use was we said anyone who would like to volunteer in that clinic is welcome. We will not require anyone.
Mm-hmm.
It includes staff. So it was initially, I was the first person to staff that room. And I think maybe there were a couple more doctors who decided that they wanted to staff it too. And that was in full,
Yeah.
the full bodysuit.
Yeah.
um, and I remember with some staff, we created this little, went and got chalk and we created this whole sort of child-friendly approach to this back door so that when they saw us in full gear,
Yeah.
the children weren't terrified. So
Mm-hmm.
we went to a lot of effort to make sure that we could take care of children in a way that would serve the families. And so I think the series of events that happened afterwards were really about fear and about administration not feeling that things were happening in a way that they could control. And one example was, again, in the early days, the pediatric offices are tiny. And we had, in terms of the ratio of heads, bodies to square footage, the highest concentration of people, which was obviously a problem
Yeah.
in the early days of COVID. And so I, together with the heads of our department, decided that I was leading our COVID response. They delegated me to do the research, create the protocols. And so we said the staff should go home because we can't have 6 people in a corner.
Mm-hmm.
While this is happening, especially if they're not doing anything. We weren't seeing patients, in the volume that we were seeing before or at all, really. And again, I think the administrators didn't like that we were directing care, and I think we're behind because their understanding was that we were closed. And so what ended up happening, and I think it took, my memory's a little spotty with good reason, but I think it took probably 6 weeks. But what ended up happening is that an HR complaint was filed against me and against the 2 leaders of the department who had delegated me to be the COVID lead. And so then everything that we were doing stopped. And that was devastating for me. It was, I can't overstate the emotional impact of that for me because I don't know if it's true for most pediatricians, but I would guess that it is based on how I see them present in the world. We take our jobs so personally
Yes.
and feel so invested in the entire team that helps us serve families.
Mm-hmm.
I've heard people describe doctors as people who give orders, and it's not my experience of medicine at all. In fact,
Yeah.
I would love for it to be a little more like that. Like I would love for someone to just do something that I ask them to do sometimes without question. But that's just not how it is. It's not ever how it's been in my practice. We work really as a team and everyone has a role to play. So yeah, it was personally devastating. I felt like the ground had shifted beneath me and I didn't really know. I felt like I didn't have a solid footing.
I imagine an HR complaint on any day would be somewhat traumatizing, but in the midst of COVID, when you are just trying to create and do everything you possibly can at that time, I imagine it would be even more so. Not
Mm-hmm.
unlike getting a lawsuit.
Mm-hmm. Yeah, and I think there's a good amount of literature around the impact that lawsuits have on doctors and their perception of their work and their perception of their um, efficacy in the world. But I imagine that this is similar to that. It was devastating, and I didn't have any understanding of how it might impact my reputation, my license, really all of the all of the outcomes of the hard work that we put into creating the careers that we had. And so, um, yeah, it was,
Yeah.
it was
So as you
just
were going through
upsetting.
that, you mentioned to me while we were talking there was, and however much you want to share is totally fine with me, but you did mention that there was an organization out there that was particularly supportive.
Yeah. So in sort of this cocoon of shame that I found myself in, I was trying to reach out to anyone that I thought could give me information about what this meant. Um, and and give me some support even about how to navigate it because HR could not, right? So their role is to
Mhm.
protect the institution. And
Right.
so really weren't able to give me any, not only were they not able to give me any information about the material of the complaint, like what were the concerns of those who filed the complaint, but they weren't able to give me any guidance about what it might mean. And so I consulted lawyers, and I don't know if I have never consulted lawyers as it relates to my profession,
Mhm.
or otherwise for that matter. And that is a dark space, right? So it was a really dark space and it was expensive. And I didn't feel comfortable, honestly, in those conversations because my impression is that they were very used to filing lawsuits on behalf of doctors against large organizations. And that wasn't the route I was trying to take. I was really just trying to understand, what are my rights? What are the implications of this? And how can I navigate this situation that's in a way that works for everyone? And so so in addition to lawyers, I had reached out to, I think, some of the national physician organizations, and that is also an interesting space. Um, I'll just leave it there. But finally, I found this group, Physicians for Just Equity, PJE, and I didn't actually, uh, it wasn't totally clear to me at the time how they did their work, but it was clear to me that they exist to support physicians who are struggling in their workplace. And so I actually reached out to the director, and I'm not even sure whether I found her name on their website or whether I, sort of cyber stalked her name in some other way. But I make that point simply because it didn't even feel comfortable to me to submit my information via their website. That's how much shame and
Mhm.
um, paranoia I felt, is that I didn't know who it would go to. And so I reached out to her via email, Pringle Miller, and we ended up communicating via email. I didn't obviously share a lot of details, but some context about what I was going through. And she was incredibly supportive. I think the first thing she said was, I get it. I get it. You're not the
Oh.
only person, and you are okay. You will be okay. And I mean, I feel that feeling that I had at the time coming back. I mean, it brings me to tears because it was such grace and generosity, and just to know that I shouldn't feel scared or alone or ashamed, was incredibly helpful. And I didn't end up engaging with their panel of services, but what I understood is that they have coaching groups, and they'll bring in a group of coaches to work with an individual physician to help them get through a moment like this. In retrospect, I wish that I had, but I don't even remember the decision making around that time. But even just hearing from another physician who had visibility at 10,000 feet and could tell me, it's okay, it'll be okay.
Yeah, that's
It's-
amazing. But it's ironic. The conversation I had right before this one, I think it was just last week, was with a doctor who runs an organization called Physicians Anonymous.
Mm.
And it's not specifically related to HR issues or lawsuit issues, but he was talking about how those are common reasons doctors do come. It's more dealing with shame and burnout and things like that, but it's another sort of free, safe space where you can go. They don't have the legal expertise that it sounds like PJE offers, but I do love to share these resources with people so that we don't suffer in silence. It's not necessary.
Yeah, it really isn't. And it made it, I think it, how do I put this? So over the course of the time that I was working before that, I think one of the things that I had felt so proud about, and I felt that I was really intentional about creating in my pediatric group, was psychological safety. And what I mean by that is being able to walk into, so the way our practice was two offices, was it like, half of the doctors in one, half of the doctors in another, in like a tiny little space. So we were all up against each other. And the beauty of that is you could walk into the room, close the door, and say, I don't know what is going on with this kid, or I think I made a mistake.
Yeah.
What do you think? Well, how would you deal with this? And my experience has been that it's not common that a doctor can say to other doctors, I think I made a mistake, or I'm not sure what to do here, because being knowledgeable and being an expert and being the pinnacle of knowledge is such a value of ours in medicine. And so that's what I felt I had before this happened. And so to lose that too was devastating.
Yeah.
And it made me think a lot about how in medicine we support one another, we support doctors in bringing their whole selves to their work. Because if we can't do that, if we can't say, ooh, I think maybe I didn't make the right choice there. What would you have done? Let me think through this, and maybe next time I'll make a different choice. And how can I mitigate whatever happened here? If we can't do that, that's ultimately not as good for our patients, but it's definitely not good for us as people caring for others.
Yeah. I love being able to collaborate with my colleagues. That maybe that is a pediatric thing. You know,
I
we
don't
we
know.
all
What do you think?
share one, we have like four doctors in one consult room, and we're constantly pulling people in to check this rash and do this whatever and talking about cases at our monthly meetings. And without that, yeah,
Yeah, I feel we as a community, I think it's worthwhile for us to try and find more ways to build that in, um, so that we can be whole people at work. And
yeah.
yeah.
So Sabrina, what next? Right? So this you went through
Yeah.
this
So
and
yeah, so the way I would describe that experience, high level, is that it made me feel very much like it was impossible to care for patients the way I wanted to. And that's kind of that's how I describe my transition publicly. And it's true, it just doesn't really cover sort of the emotional pieces of how that happened. But big picture, I think the take home point from COVID for me was that the world really doesn't think about children and families the way that they should be. And so when I left my practice, I went back to Stanford, and my intention was really to focus on understanding why the world doesn't care about children and families, but we say that we do, right? Like, I believe the children are our future, all of that, but I don't know if it really works out that way. So I went back and I did a biodesign faculty fellowship at Stanford. And the reason I chose to do that is that I had been noodling on an idea around an pediatric asthma device that would help us as physicians understand how a child and a family is using their asthma meds. Because it was apparent to me in my visits, parents are wrestling their kids to do these
Mhm.
inhalers in the office. So then what does that mean about what's happening at home,
Sure.
really? How often are they getting their meds? And, if we're ratcheting up the strength of their controllers and starting to put biologics on, shouldn't we understand whether they're actually taking their meds? So that was the concept that I worked on in the biodesign fellowship. And so the biodesign process helps you go through needs finding and the design thinking process, and then really understanding how the market functions to help innovations come to market. And the take home point from that year was that there are very significant barriers to bringing pediatric innovations to market, and they're economic in nature. And if we don't address them, we will have nothing good in pediatrics. That's really the conclusion that I came to. And so that's sort of colored everything that I do. I think that experience, I was focused on using technology to innovate for children, but also trying to understand how these technologies can make it to the market. And if we don't address these misalignments and disincentives, nothing will make it to the market.
So what's I mean, we probably don't have time to get into that. That's probably a whole other episode, but is it because there's just not money in kids, or you can't do testing in kids, or
Well,
combination?
I'll give you the three high level
Okay.
sort of things. So the first thing that most people will hear is that the markets are too small. And what that means is that we have lots of pathology in adult spaces, but in
Mm,
kids, it's a relatively small percent, right? Like less than 5% of kids are really the ones who are high utilizers.
sure.
And so there's just, for any investor, they're not going to make the return on investment
Right.
that they would in the adult. So that's the first thing. The second thing is this question of budget dust. And I remember very clearly learning about that issue from Sue Cressley, who's the incoming AAP chair.
Yeah.
But she's spent a lot of time in the payment space and the insurance space. And what she explained to me is that when you go to any individual payer, the line item for pediatric anything, so let's use the example of pediatric asthma, is so small in comparison to adult asthma or adult chronic lung disease or anything.
Yeah.
So that getting them to even sit in the room with you and want to change how they do things for that small of a number, even if you can say, I can save you 50%, it's so small that it just doesn't
Right.
motivate. So
Right.
that's this budget dust problem. And then the third thing is this concept of wrong pockets. And that just relates to any interventions that we do in pediatrics accrue over many
time.
years to many stakeholders. And so there's not one stakeholder who's like, oh, I really want to save money, and so I'm going to invest in
Right.
pediatrics, right? It has to be a group of stakeholders that come together and say, this is a value to our society. And that
Right.
makes it really hard to innovate.
Yeah, I guess we're just the little ones are just too healthy.
Well, I mean, that's a whole other topic too. And we can get
have to
into that another time.
wait until they're sick before we do anything.
Yeah.
So that's so interesting. Okay, so tell me about, because now you have this very cool company, Wellio, right?
Yeah.
Tell me how that came to be.
Sure. So as I spent more time really in this intersection between technology and child health, and as I had understood that there are existential barriers to bringing innovations for children to the market, it became clear to me that we need to find ways to create sustainable business models. So something that isn't charity driven, it's not grant driven, to basically facilitate innovation for children and families. And so that's really what I'm trying to do with Wellio.Health. It is a platform, meaning like a marketplace, or like, the simplest way to describe it is like an app store for any kinds of apps or software that is being developed specifically for children and families with all of the specific design qualities that we need, right? Age-specific design, caregiver interface, specific security safeguards, even just addressing the needs of children and families. And so, the bigger idea initially was we need an accelerator that is specifically for general pediatrics for the needs of family and children. And this was sort of a distilled version of that, is that I ended up speaking to founders of companies that are trying to address the needs of children and families. And that would be companies that are trying to address things like behavioral concerns, nutrition concerns, early intervention, sort of all of the nuts and bolts of what we do every day in general pediatrics and primary care. But by and large, these founders are parents. Maybe their technology background or a finance background, and then they become parents, and then they realize what a mess it is. It's so hard. And they get their 17 minutes with their pediatrician, every
lucky, right?
Yes, right. And it's not enough. And so they create these technologies which can have value, but then when they try to develop them, they can't reach pediatricians.
Right.
And that's what I heard over and over and over again. And so after one conversation, I thought, gosh, it can't be that hard to reach pediatricians. We want these technologies. We want to be able to help our patients, and to feel the term I always use is we want to feel like the rock star in the room. We want to be able to say, oh, to this family, I can help you. I can give you the tools that you need, and we'll get you where you need to be. And so I started creating focus groups of pediatricians for some of these companies just to get their feedback and engagement. And then from there, it became clear that we need to do it on a broader scale, and that's what Wellio is.
So what you're describing is, I think, a universal problem, and is getting bigger and bigger as there's so much noise. How do we, every time I learn about an amazing resource that exists in my community, I'm like, how did I not know that this even exists? How to connect people with what's available out there.
And how do you guys deal with that now?
So
practice, if you think about resources, how do you
It's
set that?
so challenging, right? So we try to keep this kind of like database. We have a care coordinator who sort of tries to keep track of everything. And we actually on Long Island have this really nice organization. It isn't a nonprofit. It's called Help Me Grow.
Oh, yes, of
And
course.
you know them, yeah?
Yes,
So
yes.
they, they serve children ages 0 to 5, families 0 to 5, and they act as that repository. So I have that just one point of contact, say they can help you find everything that you need. But um, I still think it's just scratching the surface. Are you utilizing AI in this in any way?
Yes. Just to backtrack a little bit, what we had in our practice was a binder, a literal binder, which I
Hmm.
think is probably just as common as these databases, but keeping them up to date is really difficult. And so the idea of Wellio.Health is that it is now your binder or your database, but it's constantly upgraded, constantly updated. And AI is used to evaluate the tools, B, make sure that the information about the tools is updated. And then within the individual tools, AI is increasingly being used. But that's sort of another subject that relates to how do we assess quality of the tools.
Yeah. So what types of things do you support?
Yeah.
Because the needs are massive. You must focus in on certain things.
Yeah. So I have currently a database. I think we're somewhere around the 500 tools range. And we've decided to focus in on behavioral health in general. And the idea behind that is that those are the most pressing needs.
Yeah.
The issue is that there is a slice of that where we're talking about mental health specifically. And when you're talking about tools that incorporate AI, for instance, they can be incredibly helpful, but there are very real risks of using digital tools in that space because what we know from the literature is that they tend to underestimate suicide risk. That's one example. One of the major things that I'm working on with Wellio is a framework for understanding quality in these tools. So in my understanding of the space, I think there are two problems. One is finding tools that meet the needs of the families, and the other is understanding which of these tools are actually going to help the family and are not going to introduce a risk that we didn't intend. And that's arguably a bigger chunk to bite off.
Yeah.
And so it's something that I think is necessary if we're going to roll out these tools. And that's what we're doing at Wellio.
So if I have a patient who I think could use, um, you know, sleep training, for example, is that something that I could tap into
Yeah, so
Wellio
there are a
for?
few tools. Yes, so that's a great question because when I think about behavioral health as pediatricians, we think about that broadly applying to things like sleep because that affects behavior. Also things, relating to feeding and parenting and so on. So yeah, there are a number of tools around sleep. They're targeted at different age groups. But yes, there are plenty of tools available to families. And I think the other thing to keep in mind is the more pediatricians and families engage with a platform like Wellio, the more there's a pull for tools, a pull and a distribution channel for these tools and high quality tools to be created.
Hmm. All right. And then what's your subscription? We have to pay for it? What's the
What's the
business
business
model?
model? Yeah,
Yes.
thank you. So it didn't make sense to me to have a pay for play. And what that means is that you have companies who pay for space, and then ultimately you become like a distribution channel or an advertising
Right.
channel for them. And that goes against the idea of this. The idea about this platform is that it's a place to find any tool, but that because of the quality framework we're creating, it becomes very easy for families and for pediatricians to understand what is high quality. So the revenues to the business come from affiliate fees. So those are a small percentage of any subscription that the family would pay for the tool. So that model is similar to the App Store.
Right.
And then ultimately, to the extent that we're able to show that the tool helps families with satisfaction, or physicians around their work-life balance, or satisfaction in terms of their practice, there's potential for a revenue stream coming from health systems that want to retain their physicians.
Interesting. Sabrina, this conversation has been so fascinating. First of all, I'm so sorry that you went through what you went through, but I'm thrilled to see where you landed.
Thank you. It was a journey, to be clear, but I wouldn't do it any other way. It's life, right?
Yeah, exactly. So, I imagine you have a way people can find you, what your website is, or any other contact info?
Sure, thanks. So we're at www.Wellio.Health. And if there are pediatricians that are interested in engaging, we have a couple of different ways. You can just go to the website and sign up. But equally, we have something called a Pediatric Digital Health Consortium. And these are pediatricians who want to be engaged in the design level, and really engaging with the different companies. And so if there's someone who's interested in that, you can access that on the website too.
Well, I am most definitely checking all of that out. I know I've been meaning to do this since we met in October of 2023, but now I am definitely going to follow through.
Thank you so much. It's such a pleasure to talk to you.
You too, Sabrina. Thanks again for joining me.
Thanks.
That's all for this episode of Reinventing the White Coat. If you enjoyed this conversation, subscribe now so you don't miss an episode. If you're interested in coaching or in being a guest on the podcast, you can reach out to me online at sharecoaching.com. Thanks for listening, and don't be afraid to live your best life.